Hello everyone, my name is Lorena Abril. I am a research assistant in the Department of Emergency Medicine, Albert Einstein College of Medicine, Montefiore Medical Center, and today I will be presenting a research entitled Pain Trajectories and New Onset Chronic Pain After an Emergency Department Visit for Acute Pain. As we know, chronic pain is a debilitating illness characterized by neuroanatomical changes, suffering, loss of productivity, and increased use of healthcare resources. This disabling disease affects approximately 20% of U.S. adults. Emergency practitioners are well situated to impact the incidence of chronic pain because they treat patients at risk of chronic pain but not yet suffering this debilitating disorder. Appropriate treatment of patients with acute pain may prevent chronic pain. It is becoming increasingly clear from the surgical literature that intervention delivered at the time of painful insult or shortly thereafter may reduce the incidence of persistent post-surgical pain. Therefore, it is important to evaluate the acute pain resolution process over time to determine whether individual patterns exist and could help to establish those acute pain patients likely to transition to chronic pain who are going to benefit of a more comprehensive therapy and additional resources. The goal of this study was to determine whether pain trajectories can predict which patients will transition to chronic pain. This was a prospective observational cohort study of patients presenting to an emergency department for acute new onset pain who were experiencing pain of sufficient severity to require an opioid prescription. Patients were enrolled at the conclusion of the ED visit and followed by telephone 1 week, 2 weeks, 3 months, and 6 months later. This study was performed in 2 academic EDs in the Bronx, New York. We included adults aged 18 years or older with a chief complaint of acute pain from any cause who were discharged home from the ED and required an oral opioid prescription. To participate, patients had to have pain for less or equal 10 days and could not have experienced pain in the same body region during the preceding 6 months. We excluded patients for the use of any analgesic medication for more than 10 days per month on average prior to the onset of acute pain and any patient who required hospital admission. Chronic pain was defined as any pain on more than 50% of days since ED discharge. We identified several pain trajectories. First, patients who improved quickly did not report pain greater than mild at any follow-ups. Second, those who improved slowly reported moderate or severe pain at the early follow-ups or at 3 months, but by 6 months did not report pain worse than mild. Third, intermittent pain sufferers reported moderate or severe pain at one of the early follow-ups and one of the later follow-ups. And finally, patients with persistent pain reported moderate or severe pain at every one of the follow-ups. We compare frequency of each trajectory between those patients who ultimately developed chronic pain versus those patients who did not. We also report whether body region in which the pain was experienced was associated with a particular pain trajectory. We approached 733 patients, enrolled a total of 484 patients, and obtained a complete follow-up data on 84% of patients. Actual results will differ slightly from those submitted in the abstract because these results come from the final analysis of the complete data. 50% of patients were adults between 18 and 44 years old, and 13% of patients were adults more or equal 65 years old. The distribution by gender was balanced with 56% of female patients and 44% of male patients. Extremity was the most common location of pain, followed by neck and back pain and abdominal pelvic pain. Chronic pain was reported by 110 patients, representing 27% of the total participants. 32 patients had persistent pain. Of these, 29 reported chronic pain and 3 did not. 95 patients had intermittent pain. Of these, 46 reported chronic pain and 49 did not. 174 patients improved slowly. Of these, 23 patients reported chronic pain and 151 did not. 107 patients improved quickly. Of these, 12 reported chronic pain and 95 did not. To evaluate the association between the location of pain and pain trajectories, we constructed four logistic regression models, in which each pain trajectory was the dependent variable and location of pain was the independent variable, while adjusted for age, sex, total MMEs prescribed, and whether or not the prescription was filled. Back and neck pain were associated with the persistent pain trajectory with an odds ratio of 2.8, and abdominal, pelvic, and fascial pain were associated with patients who improved quickly with odds ratios of 2.5 and 3.7 respectively. In conclusion, approximately one quarter of ED patients with acute pain report development of chronic pain in the affected body region 6 months later, and patients with non-improving pain trajectories are at risk of transition to chronic pain and may be suitable for more intensive interventions. Please post any questions to the comment section below, and thank you so much for listening.